It's nice to see familiar faces out there. We have somebody I saw from Choosing Wisely, Japan. So this is the first time we've had an international audience, so that's great. We have two wonderful speakers that we've collaborated with over the years. I would consider them good friends. Before we get into this interesting topic about physicians trusting their patients, we're going to do a poll and see how people, do you feel that your primary care physician trust you? So it's either a yes or no. I'm sorry, there's no in between. We were trying to predict what the result would be before the meeting. And we'll continue. Let's see, we have 25 out of 32. Maybe those 6 people don't have a primary physician that they would identify with. But it's 73% said yes, 27% no. Tara and Rachel, what do you think about those results? What's your reaction?
I think it's perhaps not surprising for this group that might be the result. I feel like there are pretty big sociodemographic differences in the experience of being trusted, and that has been documented in the literature. So if we were polling Medicaid recipients, for example, or people in low-income neighborhoods, we might get a different skew, perhaps the obverse of what we see here.
Rachel, Tara, anything to add?
I would say that for those who said no, it's not always personal, right? It might not be about you. It might not even be about the individual physician not being a trusting person. It could be a systems thing, where they're not given enough time to know you. They're not given the resources to know you. There are things in the way. So I think that's something we can explore a little bit, is that trust is not always personal.
Good point. But before we go into that, we always like to do an origins kind of question about how you entered this work. What brought you to this work that you're both so committed to around trust? So Tara, why don't you go first?
Yes, thank you. Looking back, trust is the thread through my whole career. I started out editing dictionaries and encyclopedias, where I was focused on trustworthy information as a way to have impact, and ended up working at Consumer Reports on trustworthy health information and collaborating with the foundation on Choosing Wisely, where Consumer Reports certainly used the power of its trusted brand to disseminate trusted information. But then I started to realize that trust was also about systems and not just about information. And we would try and improve trust in systems through transparency initiatives. And then I left Consumer Reports because I was so obsessed with trust, and went and worked with groups like Open Notes that focused on transparency to create trust for systems change. In that journey, long story short, I just started to realize that the biggest issue was people, and that without trust in people and between people, and without trust through leadership, we had a barrier to trust in information and trust in systems. Yeah. So I've started to evolve into more of a coaching and leadership education world, where I hope I can help leaders think about trust as people.
So Rachel, you've been involved in thinking about the patient's voice for quite a long time. So how did you enter this world of thinking about the patient's voice?
I actually thought I was going to go to medical school way back in the day. I did all the pre-med work, but I really found myself more drawn to understanding the way healthcare worked, and also what produces health, salutogenesis, if you will, the sort of understanding of how to generate health more so than pathogenesis, which led me into the world of health advocacy and to the kind of qualitative research that we do now, trying to really understand what is going on for patients and families using systematic methods of eliciting diverse perspectives and then informing system change with that kind of combination of rigor and heart. And I think trust emerges sort of de novo out of that kind of narratives work. It's something that's on the minds of people when you ask them in an open-ended ways about their experiences with care. And so I moved from ideas about advocacy or empowerment or voice into the trust space because I was led there by the thousands of narratives I've read and the many hundreds of interviews we've conducted in my lab. And then I met you, Daniel, and that became a really nice sort of way to collaborate with ABIM, trying to look at some different dimensions of trust than what is primary in the conversation, which is often how do we get patients to trust their clinicians more? This is a different take on that.
So in March 2020, 2019, you wrote a paper, Why Physicians Should Trust in Patients. So, and I was in the room, sort of, not figuratively, literally, but how did you get there? How did you think about flipping the switch on this whole idea? Because, boy, there's been a lot of work on patients' trust in physicians. There's measurements, there's tools, there is a whole set of literature that's about 30 years old or more. How did you flip the switch? What brought you to flip the switch on this whole notion of trust and being in this other direction that we normally think about?
I think one thing is very connected, Tara, to what you just said. Trust is personal. You know, it happens sort of between people in a relational space. So it is not something that can be unidirectional. And I think the research really bears that out. Trust is reciprocal. So even if our goal were to be primarily having patients trust clinicians more, that can really only happen when trust is also extended. And then the second thing is that we hear so much when we open up the space for patients and families to tell their stories about how very capable they are, how much they are the captain of their own ship, as Meg Gaines at the Center for Patient Partnerships would so often say. And so the trustworthiness of many, perhaps not all, but of many patients who really are in the driver's seat is also very apparent through narratives. So I think the combination of those things really catalyzed my interest in digging into this particular dimension of trust.
Tara, how did you flip the switch? What brought you to that notion of physicians trusting patients?
First, I'm going to just speak to one thing Rachel said, and then I will answer your question. When you talk about trust being relational, I've been thinking about how this was true for so long and how it's possibly less true now because of all these social, political, technological forces that are in the room with us. And they're disruptive, they're troublemaking, they're Russian bots, they're angry people, they're conspiracy theorists, and their voices are in the room with us. And so the clarity of the trusting relationship is harder when we're influenced by all these forces. So I just wanted to complicate the question a bit around relational. And Daniel, to your question sort of about where I have been going with this. I mean, I care about the role of leaders and how physicians, after all, are leaders in a sense, and certainly some of them are professionally leaders. There are things that leaders have learned and things that we teach in business schools, and I'm currently teaching in a business school, that I think we can bring to the conversation about trust. And there's a lot of good qualities in adaptive leadership around humility and listening and collaboration and sharing a story with someone that I hope we can bring into medicine. And I try and do that in my work, working with CEOs of health organizations, have these more private conversations where they're wrestling with trust and wrestling with the big questions that the ABIM Foundation is surfacing. But where's the space for them to reflect and reckon with all of this and think about what they can do? So I try and help them in that space, and certainly help emerging leaders and even students think about these questions early in their career, because trust is going to be a central facet of what they have to really master in their work as leaders.
I was reading Rachel's paper again today, and what I found interesting was, when you think about patients' trust in physicians, it comes out of this compliance, adherence framework, and not out of a care plan that's agreed upon by. Could you comment on that, Rachel? I thought that was really an interesting perspective on this. It has kind of a root to it that is a little bit ancient. Not ancient, but it's something that the notions of compliance and adherence are unidimensional and not about a partnership.
Yeah, and I think that is something that inhered in the medical model in this country for many, many decades, perhaps starting with sort of the Flexner report and the consolidation of the medical profession as experts. It's, I think, a lot of pressure on clinicians to be sort of held up as the experts in that way. And I think it vastly undervalues the contribution that patients make, or really the primary role that they play in producing their own health. So I've been interested in problematizing compliance and adherence as paradigms in various ways. I wrote another piece a while ago about how patient-centered care can also be sort of part of the compliance paradigm, and we need to kind of make that more complex. Same thing true of trust here. This is not about making patients adhere more to what their doctors tell them to do so much as moving us really and truly, jargon aside, to partnerships that produce health. And there needs to be mutuality there. I agree, Tara, that there are other voices in people's heads, internalized and in the room. But I also still think that in real life, when people go to their clinicians and are literally in the same room, or even in a space like this online through telehealth, that they do, the trust still happens between people despite that. And it needs to go in both directions if both parties are going to produce health. And we need both parties to produce health, because it's too heavy a lift for one without the other.
Mm-hmm.
Tara, what's your take?
I'm thinking about the community level. So I love what Rachel just said about that individual relationship. Where it can also apply or get messy is when you look at whole communities. So patient advocates, patient safety advocates, survivors of long COVID, disability activists. There are communities of people who are patients who aren't being heard. Their collective voice is not being heard, or their collective knowledge is not being believed. And I think that is a little symptomatic of this broader problem with trust in society. But we really need to pause and reflect on what wisdom is in those communities that we're not hearing, because it's an asset. That collective wisdom is an asset. And I know some of Rachel's work definitely talks about this, but we need the medical establishment to hear us and to trust us. And that can be hard because, yes, there are groups of conspiracy theorists that can problematize what a group of people think. But when the medical establishment and clinician communities minimize some of the questions, that's gaslighting. I mean, that is medical gaslighting, when the patients are contradicted, their ideas and problems are trivialized, they're denied, there are sort of stereotypes of what kind of people say that these things are wrong. So one thing I really want to do is to bring some humility and courage into the medical community to listen a little longer. And that is about placing trust, and it's not comfortable because it might go against your conventional wisdom in your training to listen to something different, or to listen when you've made a mistake and have to acknowledge it. But there's work to be done in trust building between communities too.
And this gets played out, I think, in vulnerable communities and marginalized communities, and a sense of earned mistrust. So I love that. I love this conversation about what's the difference between trust and trustworthiness. Anybody want to take that one on? Rachel, what's your sense of the difference between trust and trustworthiness?
Yeah, I think of trust as more a fragile yet strong dynamic that inheres sort of between and among. And I would take your point really well, Tara, not just people, but systems. It's dynamic and it doesn't sort of sit in one place. I think trustworthiness maybe inheres more, or can be perceived to in a party. I think when we're talking about why clinicians should trust in patients, there's the question of, is a given patient trustworthy? And likewise, to elevate trust of patients and their clinicians, is this clinician trustworthy? Have they done the things to demonstrate that they are worthy of being trusted? Things like transparency, being a reliable narrator, having conflicts of interest in check, and so forth.
Mm-hmm.
So that patients can be trustworthy too. I mean, we always talk about systems, but what makes a patient trustworthy, Tara?
Look, there's a power dynamic here, of course, where physicians typically have more power than patients in the room. Patients are vulnerable and show up giving trust with an understanding of what a medical professional is. There's more of a burden on the physician to earn it through certain behaviors. Yeah, maybe a patient isn't trustworthy, but it's not their professional responsibility in the same way. I would like to encourage patients to be trustworthy, but in systems that oppress them, they're going to not feel safe. So they might not be able to perform as trustworthy patients in that moment. Physicians, however, can learn to be trustworthy and practice trustworthiness. There are habits for developing trustworthiness. There are books about those habits. And Rachel and you have both named some of them, like being transparent and being authentic, listening well, giving people time, making sure that you're competent and expert and mastered in what you claim you're an expert in, if it's medicine. So there's a lot of work to do for physicians to earn trust. And they might feel they deserve to be trusted as ethical humans, but also there are things they need to show to earn that trustworthiness. And the researcher Rachel Botsman, though, says true trust doesn't need trust to be shown anything, because trust is implicit. Trust is what you give even when you don't know what's happening on the other side of the table.
Right. When you get in an Uber, you trust, but you don't even know it's that driver is
That's a good
trustworthy. You
example.
just get in the car. So
Daniel, can I just add one thing?
please.
That I really agree with Tara's point here about patients being sort of deserving of having trust extended to them without having to prove that they're sort of adhering to professional ethics. And I want to add that one reason for that sort of presumption of trustworthiness is that nobody else knows what a patient is experiencing besides that person. They're the only one who can narrate that. They're the only one who is with themselves all of the time in all kinds of settings, not just in the clinic. And that kind of expertise, I think, should not be as undervalued as it is. And I think sometimes what can happen in clinical encounters is that when that narration and that description of lived experiences, of symptoms, of how to manage them, doesn't fit well in the sort of diagnostic criteria that a clinician has in their head, or in the variety of treatment options that, you know, evidence-based medicine suggests are there can be a little bit of a loss of trust in the veracity of the narrative that is being brought into the clinical environment. And I think that that's a challenge for all involved. That's really hard for clinicians because they want so badly to solve the problem. But patients are trustworthy sources and trustworthy narrators of their own lives and health experiences.
Can I share a success story around this?
Yes.
Well, please go right ahead.
So talking of patients as narrators and storytellers, yesterday, Patients Like Me, which is an organization where I was the co-chair of the ethics advisory board for a couple of years, they finally released data to Mass General Hospital of the self-collected patient-reported data on ALS collected over many years by patients who really had the experience that Rachel just described, of having individual stories or even individual experiences of experimenting with their own treatments, or learning something about themselves that didn't fit with the conventional paradigm. They got together and self-organized as citizen scientists through the platform Patients Like Me to collect data about themselves and to discover, you know, treatments and solutions for themselves. This data set now has hundreds of thousands of patients' data and has been sort of securely handed over yesterday as an incredible asset for clinicians, which would not have happened if patients hadn't been frustrated with really not being heard and not seeing anything happening for them. And so physicians can trust in these kinds of patients that have this self-knowledge and the power to do something about it.
Rachel, any let's go back. Let me rephrase. We heard a little about listening as an important element to build trust of the physician. What other things build physician trust in patients? How can they begin to have trust in their patients? How do they develop that as a skill, as a part of their communication with their patients? What other things make that happen? And also, if you could talk about some of the benefits of this whole physician trust in patients, that would be good. And when I think about self-management, I always think about, how can you do self-management if you don't trust me? I'll tell you my story. When I was a teenager, I fell off a bicycle and my doctor didn't really trust me. So instead of implanting the pins subcutaneously, they stuck out so I wouldn't take a shower. It was a terrible thing to have not, have to go through that because he didn't trust me. Although I think he was smart at the time.
But the question is, what was your outcome like?
It was the same. But it was agony to go through not taking a shower for a few months because these pins were sticking out. He could have put them subcutaneously and I could have taken a shower, but he didn't want me to. So anyways, it affects care. I think the point is, it does affect the care of a patient if the physician does not trust the patient. They'll alter their treatment course, sometimes not to the betterment of the patient. So Rachel, continue on that course.
Yeah, I think you're absolutely right, Daniel, that the research suggests that this is a real phenomenon when people do not feel trusted. They will avoid care. They will avoid preventive services. They will really suffer sort of mental and physical deteriorations. And I think this has been demonstrated with various subpopulations, for example, people with HIV. So we know that it's deleterious, and it's also very commonsensical, right? Like, do you like spending time with people who you can tell don't really trust you? Would you continue to extend your trust to them? No, it creates an avoidance pattern because it really undermines our sense of self. Like, we don't feel good about ourselves when we feel mistrusted. I think your question had a few different strands. One was sort of, how can clinicians become more trusting? And another is, how can they communicate the trust that they have in patients once they've built it? So I will perhaps address that second one and see if Tara wants to address the other, if we want to circle back to it. I think in terms of communication, one thing that matters is the sort of nonverbal as well as verbal communication, because there's a powerful pressure on patients to sort of comply with expectations verbally, but you can tell if you watch when people seem uncomfortable, and you can try to dig in underneath that. I think the kind of anti-racism and anti-bias work that's happening in many sectors of society is something for medical practitioners to take very, very seriously. The research on implicit bias suggests that clinicians are at least as likely as the rest of us in society to have a lot of implicit bias, because we are all living in a society that reinforces those kind of biases. So that is a strategy. I think embracing uncertainty together is another really important piece of this. We hear over and over in our narratives from patients that they are actually quite understanding and patient with respect to the reality that not every medical problem has a solution yet. And there is a belief on the part of many in the ability of science to progress and solve those problems. But in the meantime, they want a very frank acknowledgement of when uncertainty exists and when solutions have not yet emerged. And they want to feel accompanied by their clinicians while they reside in that uncertain space. And that itself is an intervention. It's not necessarily what people think of when they take the Hippocratic Oath, but it is, from patients' perspectives, a really powerful part of the caring that inheres in healthcare. So those are a few ideas.
I love that uncertainty. We have an RFP on the street about uncertainty and how to communicate that uncertainty. So anything to add to that, Tara, about Rachel was?
Yeah, I'll just reinforce that this partnership with patients can happen. There's a historic idea of a doctor having the answers and relying on evidence, but if we tip the scales more towards the empathy and the shared story, shared purpose, and collaboration in problem solving, that not only creates trust, like in any relationship, but it also results in better outcomes. So that reinforces you. But I will add, maybe another thing doctors can do is, if they're operating in systems that are setting up the conditions for mistrust because their electronic medical record system is horrible, or they are running behind schedule because they're overbooked, or their compensation is structured badly, then fight, be an activist. If you are in a community where there are inequities, go and participate in dismantling those inequities, because these contextual things that I keep saying are being brought in the room are impacting those individual relationships. And doctors can feel victims of the system, of course, and are burned out for sure, but also they have a voice, or if you're listening, you have a voice to take up your power against the system, and do that together with others as well. You're not alone. But I think we need to make some systems changes to optimize the opportunity for trust.
So that leads me, and I'll ask Rachel to lead off on this one, because you were getting at it, Tara, is what barriers to building trust of physicians and their patients, what are they, and how do we overcome those barriers?
Yeah, I think clinicians can feel that it's their responsibility, sort of on their own, more or less, to fix problems in a sort of heroic paradigm. And while the intention behind that is so sort of lovable, the reality is that most of these problems, or many of them, are too complex for that paradigm to adhere. So I think sort of letting go of the idea of being more of a solo hero and leaning into being a trustworthy and trusting partner is sort of a paradigm shift. I agree with Tara about the systemic solutions, and I think having people who have the most power in the system sort of speaking out about its shortcomings and being part of the solution is a really powerful, again, way to enhance trustworthiness and thus to build trust. Yeah. Tara, what else to add?
Yeah, I think I addressed a lot of them, but we could go down from the system again to the individual and just say that taking time for self-awareness, reflective practice, thinking about whether the encounter you had with a patient was a successful trust experience from both sides, and talking to others about it to learn, because it's difficult to practice trust every day and to give trust every day. And I, as a coach, feel that we don't give our clinicians or our leaders or our patients time just to talk about what it feels like and process it and learn some personal lessons to bring back and try again tomorrow, and to come back and apologize or to have a difficult conversation. So those self-development things can be another way to handle this challenge.
Yeah, I really want to pick up on that. The idea of repair, I think, is a really powerful one. Think about your relationships that matter in your own lives. You mess them up, and then the real test of their strength and of the trust between you and that other person is, can you recover? Can you repair? And I don't think at the personal level that there's really much difference. I think that comes into the exam room. And we know from decades of studies from the risk management side, for example, that people are much less likely to be litigious if there is an apology and an acknowledgement. And in fact, there are many examples now in sort of the advocacy world and in patient and family advisory councils of people who have been who have really suffered because of medical errors and, you know, large problems, who can be enjoined and enlisted actually to become partners with health systems and with clinicians in making a better pathway and a more trustworthy sort of future for that practice and that organization. So never underestimate the incredible trust building value of an authentic apology and effort at repair. Your patients, if you're a clinician, will very likely be receptive.
I think sometimes in medicine, we think of medicine as so unique, and that we try and solve problems like trust within medicine, but medicine isn't happening in a vacuum. It's happening in society between people. And so the systemic problems with trust and the social problems with mistrust are really the same, and our interpersonal relationships. And the solutions we have for fixing trust with our neighbors is not very different than what we need to do to fix trust between physicians and patients. And so I think we need to be curious about the conversations outside of medicine, in restorative justice and criminal justice, for example, and in psychotherapy and marriage counseling, because those ideas really work for medicine too.
So when physicians trust their patients, patients' trust in physicians increases as well. So have you seen anybody measuring both? And is there an instrument? I think I know the answer, and you should never ask a question when you know the answer. Are there any tools, measurement tools of physician trust in patients? And have you seen any of that going on? Where I mean, it's a partnership, it's a reciprocity, and so have you seen any things like that?
Rachel?
Yeah, I mean, we wrote in our JAMA piece that you referred to, Daniel, a little bit about this. There is one measure, but I don't think it gets at all of the dimensions that we've been highlighting here. So I think there's more opportunity in the measure development world to get better at this. It is something that we measure, if you will, in qualitative studies, I think quite effectively. And I do think that there's at least a budding literature that does demonstrate the reciprocal relationship you were just referring to, that the more patients feel trusted, the more likely they are to extend trust. And a lot of that comes out of the qualitative literature, where people say, like, the minute, you know, I feel trusted, I feel trusting. And so I think we know that there's at least a fledgling evidence base to support that. And I think it can be built on. I'll also add that being trusted by your clinician makes you trust yourself more. And that is a pretty important part, particularly perhaps for people who live with chronic health conditions, which is a hundreds of millions large group, that the building of self-trust and a sense of self-efficacy, as well as sort of trustworthiness and judgment, can help people live better with their own conditions the 99.999% of the time that they are home, rather than the 0.001% of the time that they are in the clinic. But it goes an awfully, awfully long way when their clinicians extend trust towards them.
I love that you brought up the self-trust. We don't talk about that. We talk about all the dyads except for the dyad between ourselves and our brains and our feelings.
Me, myself, and I.
That open eye, that's right. We have a lot of good comments. So if you don't mind, I want to go to those comments, and then we can return and you can do some closing remarks. But our colleague from Public Agenda, David Schaefer, had two good comments. My colleagues and I have surveyed people with Medicaid and PCPs about physician trust. David, do you want to come online, and we'll pin you and you can talk about that? And then you had another comment, which I hope to find, that seemed very pertinent. You might give that one as well, about Mary Catherine Beach as well. So David.
Yeah, and pin. Let me turn on my yeah, well, I'll start with Mary Catherine's research because it's interesting. I mean, she looked at notes, at physicians' notes about their patients, and she found a much higher preponderance of judgmental comments about Black patients than white patients in written notes. And then, yeah, so this is a few years ago. It was just before the pandemic that we finished the research, but it was about, we surveyed physicians, primary care physicians, about their trust in, and specifically in people with Medicaid, and vice versa, people with Medicaid's trust in primary care physicians. And you know, and in part that was really driven by what we had been hearing in other projects qualitatively about people feeling mistrusted by their physician. So, you know, we just kept hearing it, and then And then we sort of took that up as a research question. I put a link to the report there, but one of the things that we found that I think was really encouraging was that when we asked physicians what makes them trust patients more, one of the things was taking a more active role in decision-making about their care, which I thought was a really sort of encouraging finding. And then I think to the question of measures, and this is, then I'll stop after this, but when we did that research, there was only one measure of physicians' trust in patients. I don't know if there's anything more, but it was very much out of a world of people with substance use disorder and sort of physicians' trust for patients with that specific condition. So it did, I think, Daniel, as you were saying, that it kind of came out of this world of maybe compliance and even mistrust in patients. And so I do think that like there's definitely a lot of opportunity for some new measure development there.
Tara and Rachel, any reaction to David?
Your research is really important. The word judgmental jumped out for me, and I think it manifests in a few ways in what you shared. Open notes, which I helped with a few years ago before it was legislated, that was a kind of transparency which I hope would help physicians be more reflective about what to put in notes that began a partnership and began a conversation. I'm pretty horrified by what you just shared about Black patients. But I think that there's also, when we talk about patients getting involved in their care, we can be judgmental in that too, because we're making assumptions about the resources they have to get involved to whatever degree. Sometimes we say the patient should take care of themselves better, but if you knew more about their lives, you might understand that they're doing their best. So I think, again, we need to be humble as well as do the work to take away our biases so that what you reported changes. Rachel.
Yeah, that really jumped out at me as well, David. And I can't wait to dig in more on your research. But building on Tara's point, I think one of the things that will really help with this augmentation of mutual trust is to let go of the idea that clinicians should have a language that they speak about patients in, and then a different language with which they speak to patients, because there's an insidious process, I think, that happens when we use an objectifying, even if not directly prejudicial, vocabulary, and you can't turn it off. You are conditioning your own brain, your own thought pattern, and it's going to leak out into the clinical interaction. So really respect open notes, as Tara said, as a sort of effort to start addressing that. But I think it needs to go pretty deep. You don't want to be, you need a space to vent, right? If you're having a hard day as a clinician and you need to say, hey, I'm really having a hard time here. Let me practice my mindfulness and discharge this. So everybody needs that. But in general, we need to have a behind the scenes vocabulary that we would be very happy for patients to overhear pretty much everywhere.
There's an interesting comment about if you're a clinical practitioner in a for-profit system, how do you build trust within that structure? What do you think about that? A lot of value judgments in that statement. I recognize, but it.
Yeah. Okay. I'd love the person who asked the question to help answer it, but in broken institutions everywhere, we manage to find trusting relationships in spite of the context. And that often is through authenticity. And that's something that I mentioned in an article that you may have shared a link to already, that we published in JAMA on trust and transparency, which included authenticity. But to acknowledge to your patients the reality that you're both seeing and the limitations that you're both experiencing. You don't have to be silent or defend the system. You're obviously a clinician. If you're a professional, you are there for the right reasons, working within a flawed system. You can ask questions to your patient about what they're experiencing from that system and what they think you can do.
Jane Berger, can you come online? We'll pin you and you can ask your question.
Can you see me?
Not
No.
yet, but keep talking and we'll pin you.
Okay. So I guess my question is, as the relationships have become more transactional, the long-term relationships that many physicians have historically had with their patients has been reduced throughout the years. And I would like to know what you all think about how this has impacted the dyad of trust. The second thing I will say very quickly, that I was in the middle of typing, which was this for-profit relationship of healthcare providers in the for-profit world. Actually, we've done a fair amount of research on this and found that initially it does negatively impact trust, but as the relationship extends, that negative impact is definitely reduced because the relationship between the two people and the physician or provider ownership is reduced and taken on a different path. So I want to ask the question, but I also want to share on the for-profit piece, because I've been following this for a number of years. Thank you.
Any, Rachel and Tara, any reaction?
Do you want to take anything on the transactional side?
Yeah, why don't you start there?
Yeah. Go ahead, Rachel.
Yeah, I was just going to say, yes. I mean, these are the kinds of system problems that Tara's been referring to throughout this discussion. I think the comment she made earlier about sort of finding spaces despite the challenges applies here as well. I think the challenges of for-profit healthcare may not be unique to for-profit healthcare because our entire healthcare quote unquote system in the United States is predicated on a capitalist sort of profit-making model. Like, it's kind of no matter where you are, it's quite different than the system in other countries. So I think these are pervasive issues, and I think that they put pressure on the amount of time that people have, and trust is something that does take time to build. I do think that the open notes and the sort of transparent medical records are some ways to get around it. I think the kind of patients like me, the tools that allow patients to share more ahead of time with clinicians can help to mitigate that. And I think there's some good emerging research about that, particularly where there's a longer term care arrangement and there's some capacity on the part of patients and families to, for example, do online, patient reported work ahead of the visit, which is more true in some of the chronic disease spaces than for people with emergent problems or literacy challenges. But still, I think that those are some solutions.
I would say, though, that some transactional relationships can be trusting and are enough. Not every, of course, but Airbnb, they gave the best talk on trust I ever heard. And really, we never meet the host of these places we rent, but the technology, I mean, we can argue about this, but imagine technology can be effective and trustworthy for a transaction and satisfy everyone in a particular context. So I don't think we need to dismiss transactional as necessarily bad and untrusting. I mean, blockchain, which I never understand, is all about building trust without humans being involved at all. And it kind of is a trustworthy system. So it's a complicated question.
So there's been a little pushback about what's more important. Is it more important that me, the patient, trust my physician rather than my physician trusting my patient? And there's Ashmi Ali. Could you come on and talk about what you had in the chat? Okay. Well, that was a point that she was making, and it was kind of reinforced. And Mark Feldman said, well, what if, the patient doesn't really deserve trust? He's not trustworthy. And Sarah Krug has done a lot of work in how people don't really tell the truth all the time. So what do you think about that?
Look, I'll be really quick with this. If we reimagine health as a partnership, then it's not an either or of who trusts whom. Like, a partnership is the integration of trust. Rachel.
Yeah, agree, of course, that not all patients are immediately trustworthy. But I think that, it reminds me of how, people can raise sort of a question about, for example, quote unquote, reverse racism when we're talking about racism. But we do know that we have sort of a structural system that has advantaged some and disadvantaged some. And I guess I feel somewhat the same about patients. Like, of course, there are going to be, for example, some people who are seeking pain medications. And that is, yes, David, that tool that I think you're talking about, right? That's the one that's sort of measuring, is your patient here to try to get something out of you, and it's going to lie to you and is going to use you. And yeah, that's going to happen. But I'm not sure that focusing on that, what I believe is a relatively small percentage, is kind of useful to the larger endeavor. Just like I don't think focusing on anti-racism is necessarily useful to the anti-racism endeavor. And further, I think lots of people don't tell all of the truth when the trust isn't established yet. And that's true of students and teachers. It's true of people in therapy and their therapists. And I love, Tara, your examples of where else we can learn from. I think that those same dynamics in here. And so giving some grace to patients and knowing that you're not going to hear everything that is shameful to them, that makes them feel vulnerable right away, and not casting that as sort of a failure to tell the truth, but rather a sort of stage in the relationship development, is perhaps more useful.
Well, the partnership aspects of this whole conversation are really sticking out to me. It's not one or the other. It's how do we build a partnership, a relationship that we both trust each other and can work together in a partnership way and do what's the best science with my patient preferences in mind.